What I'm going to talk about today from a surgical perspective is how we handle pulmonary hypertension and right heart failure. And quite honestly, from a surgeon's perspective, what I'm worried about is right heart failure because I want to get out of the operating room. And Steve is going to talk a little bit more about the pulmonary hypertensive component of this momentarily. And what I'm concentrating on is the inability of the right ventricle to adequately fill the left ventricle. Because when we're talking about right heart failure, getting down to the very, very basics, that's what we're talking about. Because if we don't have an adequate end diastolic volume in the left ventricle, no matter how much inotrope we have, no matter what we do to the patient in terms of pacing, controlling his rhythm, he is not going to have an adequate cardiac output to survive off the heart-lung machine. And this can happen in multiple surgical settings, the first of which are the types of procedures that go on at every institution that does cardiac surgery, emergency cases, where patients come to the operating room in poor condition. They may have multiple vessels infarcted, or they may just be hypotensive for a period of time. But we very commonly see this in the setting of acute right coronary artery syndromes, and the patients are having inadequate blood supply to the right ventricle. The similar pathophysiology can occur during long procedures, during which time the aorta is cross-clamped. The way that we preserve the hearts during standard cardiac surgical procedures is to keep the heart cold, but also to intermittently supplement it with solutions that have a high potassium to keep the heart arrested, but also some blood to deliver some oxygen. It's pretty much the standard nowadays. But the longer the heart goes without normal blood flow, the more damage there's going to be. When you look at some of the more specialized treatments of people like myself who deal with heart failure, we see two very common settings. One is in cardiac transplantation, where anywhere from 10 to 40% of patients after cardiac transplantation have some degree of right heart failure. And the reason for that is really quite simple. If you can imagine going to a gymnasium right now and asking yourself or a friend of yours who doesn't go to the gymnasium too often to lift a 100-pound barbell, you may not be able to do it. But if you gave yourself or your friend 6 months to do it, you'd probably be able to do it because you'd be able to work up to overcoming that resistance. Well, most transplant recipients have pulmonary hypertension because of the chronic left heart failure. Most cardiac donors, on the other hand, are young and healthy, and the right ventricles are not used to pumping against a high afterload. So if you go and put this nice, healthy heart into a patient with a high pulmonary vascular resistance, there's going to be some problems. And despite what we do with trying to match up size and utilizing the right organs, we can come up with situations, and do very commonly, where patients have some degree of right heart dysfunction, which can be manifested as either overt failure or prolonged requirements in the ICU for inotropes. Another situation would be those situations we put in ventricular assist devices, and we'll talk about that a little bit this afternoon. But when you put in these ventricular assist devices, you all of a sudden unload the left ventricle. You empty the left ventricle. And what that does is it straightens out the septum, and it removes the fulcrum upon which the right ventricle contracts. So just like if you got rid of the breastbone and tried to move your arms up and down, the pectoralis muscles don't have any fulcrum upon which to contract. A similar situation occurs when we use ventricular assist devices. Regardless of the etiology, what we have is poor myocardial performance. It can be because of the inadequate protection, despite the fact that we could do it by the book. It could be because of the ischemia, because the patient has been cross-clamped for a long time. It could be contributed to because of tricuspid regurgitation, particularly in those patients who have significant cardiac dysfunction, or in the transplant setting, these people usually have dilated tricuspid annuli. And every time the heart squeezes, part of the blood goes in the right direction, part of it goes the wrong direction. And the end result of that split flow is that we are not filling the left ventricle adequately. So by definition that I've given you, we have acute right heart failure. Patients can have an elevated pulmonary vascular resistance, as I told you in the heart transplant situation, but other situations can lead to acute pulmonary vascular resistance elevations. Those patients who are hypoxic and hypercarbic, patients have the pulmonary vasoconstrictive response to those settings. And even in the operating room, when we give protamine to reverse the heparin, depending on the patient's very idiosyncratic response, but when you give the protamine through a peripheral vein and it gets into the lungs, and all that histamine is released, we develop pulmonary vasoconstriction. And I would be willing to bet there's not a single cardiac surgeon who does not at some point in time identify that as a poor problem that they have come across. And then finally, as I mentioned, the alterations in the cardiac geometry. Well, the way that I treat that in the operating room is the way that most people do, and that you really just have to identify the etiology and treat it as you're able to. In a situation where the patient is ischemic, either because of an acute coronary occlusion or perhaps even because of air emboli. Now, that's something that most people don't think about, but the right coronary artery is the most anterior vessel on the aorta. And in a patient who's supine in the operating room, any air that's left in the heart after a cardiac surgical procedure most likely will come up, and if there's not a root fen in, will go down the right coronary artery. And having air in the coronary is equivalent to having an embolus in that coronary, so there's no blood flow to the tissue. And the way to treat that is quite simply just to wait it out, try to maintain high perfusion pressures in the operating room, and eventually the air works its way out. The ischemia resolves. We now have adequate tissue perfusion, and the right ventricle should recover. In the situation where we have severe tricuspid regurgitation, the way to do that is to go back on the heart-lung machine. You don't even have to arrest the heart, keep the heart beating, and do an annuloplasty, or in extreme situations, you can even replace the valve. But most of the time, just doing a quick annuloplasty will help, and by not arresting the heart, you shouldn't incur any further oxygen debt. The next situation is that situation of the elevated pulmonary vascular resistance. Well, quite simply, you will treat that with inotropes and vasodilators, and I won't get into that just yet. We'll let Steve tackle that. And in the situation where you have a ventricular assist device and you have altered ventricular geometry, as counterintuitive as it may seem, the thing to do is to come down on your flows and to leave some blood in the left ventricle. What I'm going to briefly go through in the next couple of minutes is some of the short-term ventricular assist devices that we can use and others, and some people have used for right ventricular support. The Abiomed is the oldest approved FDA device, and the one that is most commonly used. The schematics of the device are shown here, where you can cannulate the left ventricle, the right ventricle, or both, and quite simply it takes blood from the right atrium, goes back to the pump, and it's a pneumatic driven system, and that big box you see in the lower right-hand corner is actually the console. And what it does is it provides a burst of air which will unload the pump and deliver blood out into the pulmonary artery distal to the valve. If you go and look at the Abiomed database, only 14% of the patients in that database have had RVADs put in as isolated therapy. Somewhere lost in the database, however, is that 52% who have biventricular assist devices. It could be that the left ventricle is doing okay, but because of either unfamiliarity with insertion or just because there's a question about the left side, oftentimes surgeons will put in 2 assist devices. But most commonly, with TEE, you can certainly discriminate left ventricular versus right ventricular dysfunction. And certainly the key to success is early insertion. You don't want to be on the heart-lung machine for 10 hours trying to figure out what's going on. You want to identify the problem. If you can't fix it acutely or quickly, then move right on, put the device in, and get the patient out of the operating room. If you go and look at the registry, the column on the far left is those post-cardiotomy patients. And about 30% of those patients who have right ventricular dysfunction post-cardiotomy go on to survival in the Abiomed database. The Thoratec VAD is another device which is a paracorporeal, meaning it sits on the body as opposed to being inside the body. This is a device that can be used in multiple different configurations. Again, LVAD, RVAD, BiVAD. It can be used either as short-term use or long-term use. They've actually, in the last couple of years, developed a portable driver that's about the size of most people's computer bags, and people can be discharged on that. The nice thing about this pump is that it can be used for any indication you really have, and this is an example of some of the variations. You have an LVAD setup, a BiVAD setup, or two BiVAD setups, and it's a very flexible device. This is a device that I first encountered when off-pump coronary bypass surgery was really starting to become the rage. And in fact, to try and improve outcomes and to try and increase the population of patients who could be performed without standard cardiopulmonary bypass, this little AMED pump was devised. And in fact, the cannula in the right atrium and the one that goes into the pulmonary artery is about the size of a pencil. And we actually have used it for an RVAD after a patient had a heart transplant with right ventricular dysfunction, kept it in for 3 days, and the patient did well, and is about 3 years out now. There's several other devices in development or in trials right now. Both Levitronics on the left and the Medtronic on the right are variations of a centrifugal pump that are being evaluated now. Some of the more ingenious and intriguing pumps are those pumps that can be put in either percutaneously or direct. And this Impella device is a device that is designed to deliver support for about a week or so. It can provide, as you see, about 4.5 liters of flow. And the tip of that pump will actually suck the blood in. And if you move up the shaft a little bit, you can see a few little openings, and that's where the blood will be delivered. So most of this pump is about 6 inches in size, and it's delivered on the end of a 9 French catheter. This schematic shows it being put in directly in the operating room through the ascending aorta, and likewise it can be used directly through the pulmonary artery into the right ventricle. The tandem heart is another interesting device which has applications both left and right heart dysfunction. It's a centrifugal pump, but this pump can be put in through the groin, through standard cannulation techniques, and it can be used as a transeptal left ventricular assist device, or it can be used as a right ventricular assist device. And certainly axillary flow devices, which I'll get into this afternoon, are the second generation of ventricular assist devices. Have both the Jarvik on the right and the HeartMate 2 on the left have been used off-label as right ventricular assist devices. So in summary, the initial treatment of right ventricular failure from the surgical perspective is to identify what's going on, evaluate it, figure out if there's anything you can do about it, and to treat whatever you can. In the situation where there's nothing that you can do, then there are many different devices which are available and can be used in this setting. Thank you.
So I'm going to talk more on the medical therapies for pulmonary arterial hypertension, and I think it's an important subject because there are many new and approved therapies that weren't available as recently as 10 years ago. We now have 5 FDA-approved medications for the treatment of pulmonary arterial hypertension. Whether or not some of these, all of these can be used in the immediate post-operative period in patients who've had any kind of cardiac surgery, I think still remains to be determined, but I think we're going to be seeing more patients on these therapies coming in who might require cardiac surgery as well. But before we talk about these therapies, I think it's important to know the new classification of pulmonary arterial hypertension, and I show that over here. The first subcategory, we refer to this as the World Health Organization classification, published 2 years ago, is the pulmonary arterial hypertension. The first one is idiopathic. So we talk about idiopathic pulmonary arterial hypertension. That's a disease formerly referred to as primary pulmonary hypertension, or PPH. And that's really the prototype illness when we talk about pulmonary arterial hypertension. And most of the studies that have been done in patients with IPAH. It's a little bit more difficult to say now compared to PPH. So a lot of us still refer to the disease as PPH. And if you look at the studies, they're now inclusive of patients with other forms of pulmonary arterial hypertension. So most of the studies that I'm going to refer to have studied all of those various groups. Just to finish up this classification, there are patients with pulmonary hypertension. Number 2, I skipped through, that's cardiac causes of pulmonary hypertension. Number 3 is pulmonary causes of pulmonary hypertension. The 4th category is pulmonary hypertension due to chronic thromboembolic disease. And the reason and rationale for this particular classification is because we're trying to do it by treatment groups. all four of these treatment of these different groups probably have different therapeutic modalities, and whether or not the treatment for pulmonary arterial hypertension from group 1 you can cross over to the other groups, I think still remains to be determined to a large extent. In terms of the pathogenesis of pulmonary arterial hypertension, that's shown very nicely in this schematic over here. But the most important thing that I want to highlight from this is the vascular injury that occurs as part of pulmonary arterial hypertension. And it probably happens in all forms of pulmonary arterial hypertension, where you get downregulation of certain chemokine, cytokine substrates that might be vasodilatory in their effect, and you get upregulation of other substrates which might be vasoconstrictive in their effects. So for example, you can see over there that you have nitric oxide synthase that's downregulated, you have increased prostacyclin production, increased thromboxane production, and increased endothelin production. And this is very important when we talk about the various therapies that we use, because what we're trying to do with a lot of these therapies is restore the imbalance. This slide shows the what the indications for lung transplant have been over the course of the last about 10 years. And the reason I show this is because in 1990, about 10% of our transplants were for PPH. In 2001, it was about 2 or 3% of our transplants were for PPH. And that's a direct attestation to the therapies that are now available for the treatment of pulmonary hypertension. The first therapy that came to the fore was calcium channel blockers, and this was from a study published by Stu Rich in the New England Journal 13 years ago. And in a sense, this study did us a big favor, but it also did us a little bit of a disservice at the same time, in that he showed that there's definitely a subgroup of patients. In his particular series, there was around 20-25% of the patients who had a very good response to high-dose calcium channel blockers compared to various historical groups. The disservice he did by this, and I don't mean this with any disrespect to Dr. Rich, he's one of the leaders in the field, but a lot of people cottoned onto this, and with the take-home message being that pulmonary hypertension you can successfully treat with calcium channel blockers. And a lot of patients have inappropriately been put on calcium channel blockers where they're not really or true calcium channel blocker responders. In his original study, he defined a response to calcium channel blockers as a 20% decrement in both the PVR as well as the mean PA pressure. And in his study, 25% of the patients had such a response. The figure shown over here, 7%, is more likely the number of folks who have a true response. And the new definition of a meaningful reduction in PA pressures is shown over here. Patients have to have a decrease in their mean PA pressures of at least 10 millimeters of mercury to less than 40 millimeters of mercury with a maintenance or increase in their cardiac output. This is taken from a recent French series published in abstract form. It hasn't hit the peer review literature as yet, but they looked at patients who had an acute response to calcium channel blockers and looked for long-term response over here. And as you can see, the 7% number over here, only about 7% of patients with IPAH will have a long-term response to calcium channel blockers. And for these various other diseases, you can say it's almost worthless to put such patients or even trial them on calcium channel blockers. The first medication that was FDA approved, and this was, I believe, in 1996, was epoprostenol, or more commonly referred to as Flolan, which is a prostacyclin derivative. And the study was published in 1996 in the New England Journal of Medicine. The study was actually stopped early because of the marked difference in survival between the placebo arm and the treatment arm. And it's really become very difficult and unethical to do studies of treatments for pulmonary arterial hypertension with mortality as a primary endpoint, because we now have an effective therapy that does alter the natural disease course of this condition. There are problems and hassles associated with Flolan. It's given as a continuous intravenous infusion. It has a very short half-life. Patients cannot be discontinued from their medication. The half-life is a matter of 1 or 2 minutes. Patients have to mix up their little ambulatory pumps on a daily basis. They have to keep it on ice. And there are obviously the problems with having a central catheter in place on a long-term basis. The danger of coming off Flolan for any length of time is that you can have cardiovascular collapse. So it's not the kind of medication that one should look to start for an acute crisis with a view to patients coming off, because you never know if patients can come off this medication, and you run the risk of rebound pulmonary hypertension if the medication is discontinued. It does have some side effects as well, shown over here, primarily flushing and jaw pain with chewing. If you look at the long-term hemodynamic responses, and if you just focus on one, let's look at the mean PA pressure, it's not that dramatic, 61 down to 53. But yet a lot of these patients will revert to New York Heart Association Class 1 or Class 2 that isn't fully reflected in the hemodynamic profile. So one of the messages as well is that you can't really rely on echocardiogram, for example, to reliably follow these patients. And usually we follow 6-minute walk test, functional status, and hemodynamics. We usually cath them at least once a year after starting them on this therapy. If you can convert patients to New York Heart Association functional class 1 or 2, they have a distinct improvement in survival. Some of the patients will stay 3 or 4s on Flolan. It's not the panacea, and there is a small subgroup of patients who will have progressive disease that might need to go on to transplant or other therapies. But the key is if you can follow them and see what they do functionally, you'll have a fairer idea of how they're going to do from a clinical standpoint. The most potent vasoconstrictor in the body that we all have is endothelin, and we now have some endothelin receptor antagonists, primarily Tracleer. Tracleer is a dual receptor blocker. It blocks both the A receptor and the B receptor. There are some endothelin antagonists that are currently under development that are only receptor A blockers, and there are theoretic reasons why these might be more beneficial than dual receptor blockers. So look out for 2 medications, the one's Taxotan and the other one's ambrisentan, and which might be approved later this year or next year sometime. But this was a study that was published in the New England Journal looking at bosentan versus placebo based on the 6-minute walk test, which has become the de facto gold standard for therapies of pulmonary arterial hypertension, showing a significant difference in the groups treated with bosentan versus placebo. The approved dose is 125 BID. As you get up to higher doses, you have more hepatotoxicity. So generally, we keep patients at 125 BID is a standard dose. Not only does it result in an increased distance on the 6-minute walk test, but the patient's Borg score, which is an index of dyspnea, also improves as well as their 6-minute walk distance. The next drug that was approved or did receive approval is another prostacyclin analog, and that's Remodulin or treprostinil. Remodulin is the trade name, and this is given rather than as an intravenous infusion, as a subcutaneous infusion. It has a longer half-life, and the patients need to change the site of the infusion every 3 days. It's kind of like an insulin pump, very similar to that. Remodulin is also being studied now as an inhaled medication, and it's also recently been approved for intravenous administration with some advantages over Flolan in that it has specifically a longer half-life and you don't have to keep it on an ice pack. This was a study that came out and was published, and you can see if you look at the 6-minute walk distance over here, after week 12, it was only 16 meters, a 16-meter increase in the 6-minute walk distance. And now you might say, well, in 6 minutes, what's 16 meters? That's like a hop, skip, and a jump. You know, it doesn't mean that much. But you'll see that there were some problems with the study that I'll get into. And actually, the company had a tough time getting this through the FDA, although it is approved now for PAH. This is the setup over here. This is the little pump, subcutaneous infusion. And this is the big problem, or one of the major problems with Remodulin, is that it does cause a site reaction, which appears to be some kind of idiosyncratic type of response seen in a lot of the patients, and actually controlling the pain from the site infusion is one of the biggest problems. And this was a problem with the original study in that a lot of the patients were underdosed because of the site pain. But as you can see over here, as you increase the dose, if you're able to get the dose up, then the patients are going to have a response to this medication. The site pain isn't dose-specific, so even if the patients do develop site pain, the key is to push on and try and control the pain by whichever means you can. Another medication recently approved just this year is inhaled iloprost, which is being marketed under the name of Havas. This has been studied primarily in Europe, shown that it does have significant benefits, also based on the 6-minute walk test over here compared to placebo. So that's the 4th FDA drug that's been approved. It's the first non-invasive prostanoid, and it has obviously advantages of local delivery with less systemic effects. The biggest problem with inhaled iloprost is that it has to be given 6 to 9 times a day. Patients don't need to wake up in the middle of the night, but it's still a logistical problem in that each treatment takes about 10 or 15 minutes, and it's a big commitment on the part of the patients. This is the unit shown over here, which weighs about 7 pounds, and it also needs an electrical outlet for its application. So you might be able to get patients off Flolan or Remodulin, but this unit has its own inherent problems, and the company, I believe, is working on a smaller unit at this time. As I mentioned, inhaled treprostinil is also being worked on, which has a longer half-life. The ACCP chest, our governing organization, American College of Chest Physicians, came out with their evidence-based clinical practice guidelines that were published nearly a year ago now in Chest, which is where they provided guidelines for the therapy of pulmonary arterial hypertension. And I'm going to introduce you guys to the most complicated PowerPoint slide I've ever made. So hang with me here. If you have a seizure disorder, you might want to close your eyes. So they said, first thing is we're going to look and come up with our recommendations based on the level of evidence. So over here we have our evidenceometer: good evidence, fair evidence, low evidence, and then if you have no evidence, you always have expert opinion. And then in conjunction with the evidence, we're going to look at the benefit. So the level of evidence as well as the amount of the benefit, which could be substantial, intermediate, small or weak, non-conflicting or negative. And then based on various combinations of the evidence and the benefit, we'll have our final recommendation. So we have our recommendometer, and you can have way at the top, an A recommendation, which is strong. And these are the various combinations and iterations which would constitute an A recommendation. So if you have good evidence of an intermediate benefit, it's a level A. Then we have a moderate or B recommendation. And an example of that would be fair evidence of an intermediate benefit would give us a B recommendation. C, which is a weak recommendation shown over there. Inconclusive is if you have no evidence or conflicting evidence. And then lastly, a negative recommendation is if the drug or intervention is deleterious. And then, to finish off, expert opinions. If the experts feel that it's a strong recommendation, it's an EA, EB, or EC. So that's the basis, and now let's move through the recommendations. Therapy for pulmonary arterial hypertension, New York Heart Association class 2, 3, and 4. 1, generally, we tend not to treat. So general care, oral anticoagulants. B for idiopathic, EC for other forms of pulmonary arterial hypertension, diuretics and oxygen. There have been no studies on these, but most people are in agreement that you should treat patients appropriately with those. So that's an EA. Acute vasoreactive testing, that gets an A for IPAH, EC for other forms of PAH, and if you recall that French study I showed you would attest to that being an EC. Oral calcium channel blockers, a B for IPAH, provided they're responsive to an acute challenge. EB for other forms of PAH. I think it should be more like an EC with that new data that I showed you. If they have a sustained response, then continue the calcium channel blocker. If they don't have a response, or if they're functional class 3, then bosentan gets an A, IV epoprostenol gets an A, and then various prostanoid analogs, including subcutaneous treprostinil gets a B, inhaled iloprost gets a B. Beroprost, which I didn't mention, that's an oral prostacyclin analog that's not being developed further, got an I. If patients are New York Heart Association class 4, then you go with the gold standard, which remains Flolan, gets an A, bosentan a B, treprostinil a B, and IV iloprost, which hasn't been trialed in the US as yet, gets a C. And then at the end of the day, if everything fails, I think we had lung transplantation down over here, which I'll be talking about tomorrow. At the time that this was published, July of last year, people were using sildenafil. There were some anecdotal, small series, retrospective reviews attesting to the utility of sildenafil, a phosphodiesterase type 5 inhibitor for the treatment of pulmonary arterial hypertension. And I'll show you some recent data on that. So sildenafil, everyone knows what the other name for sildenafil is? By a show of hands, let's see. Everyone know what the name of sildenafil is? Okay, next question. Who uses sildenafil? Well, I admit I use it all the time in my patients. And this is the data of a large sildenafil study that hasn't been published as yet, was presented initially at the CHEST meeting last year in Seattle, and which was basically a positive study. They trialed it at 3 different dosages, 20, 40, and 80, 3 times a day. For those of you who didn't raise their hand, sildenafil, the other name for that is Viagra. Primary endpoint, once again, was a 6-minute walk test with hemodynamics. And these were the results at the end of the day. All groups increased their 6-minute walk distance, and you could say, well, if you put anyone on sildenafil, they're going to walk a little bit faster. Or if you count the sideways that they go as well. Anyway, it had significant changes in the hemodynamics as well, cardiac output and PVR. And it just got approved last week by the FDA. The dose that got approved was 20 milligrams 3 times a day. This is the long-term follow-up data that was presented at the ATS last month, showing that not only was it good short-term, but it was good long-term as well in terms of maintenance of its positive benefit with sustenance and maintenance of the 6-minute walk distance change, 54 meters at 12 months. So just approved as of last week by the FDA, and it's going to be given a new name and marketed under the name of Revacia. Revacia. So look out for Revacia. Actually, the drug company was very smart when they studied this drug, because Viagra is available at 25, 50, and 75, and they thought, we're going to study it at 20, 40, and 80. And so it got approved at 20. So it's not to say that 25 doesn't work. Anyway, so I think with this new data, sildenafil is going to take its place as a recommendation. And there's even some anecdotal evidence that's coming out that patients who are class 4 will have a good response to sildenafil. So I think we're going to see a lot more of sildenafil, aka Revacia. So these are the medications that I have discussed. I'm not going to mention more of them in any detail. These are the ones that remain under investigation. So it's an exciting area. We're going to see more therapies coming to the fore. And the obvious question then becomes, what of combination therapy? What if you take a little bit of a prostanoid and a little bit of sildenafil and maybe throw in a little bit of an endothelin antagonist? What you're going to get? Well, we don't know. It makes intuitive sense. Combination therapy should work. It works for congestive heart failure. You look at any condition that we've made significant inroads in. But I'll just warn everyone out there that we need to do the studies first. There are drug interactions that we're unfamiliar with. For example, if you mix Tracleer, bosentan with sildenafil, the sildenafil level will go down by about 50-60%. The Tracleer, bosentan level will go up 50-60%. So before one jumps at using these various combinations, one has to do the studies. But I think that's where the key lies in terms of impacting ultimately on pulmonary arterial hypertension. So we need to do the studies before we use combination therapy.